Hi everyone, this is Doc Ina, and welcome to my lecture on pulmonary disorders in pregnancy. To download my lecture deck, please go to my WordPress site, Doc Ina Obigaine. Reference for this lecture is Williams Obstetrics 25th edition, chapter 51. This is the outline of my lecture. We'll just first do a brief review of the physiologic pulmonary changes induced by pregnancy, and then we'll discuss four of the most common pulmonary diseases in pregnancy. This chapter of pulmonary diseases in pregnancy is quite long, so I just chose the most common four pulmonary diseases. So here are the common physiologic pulmonary changes induced by pregnancy. First is the vital capacity in the inspiratory capacity increases by approximately 20%, especially during the late pregnancy. The expiratory reserve volume decreases from 1,300 ml to approximately 1,100 ml. The tidal volume increases approximately 40% as a result of respiratory stimulation by progesterone. The minute ventilation also increases 30 to 40% due to increased tidal volume, and as a result, the arterial PO2 increases from 100 to 105 mm Hg. The increasing metabolic demands cause a 30% rise in the carbon dioxide production. However, because of increased diffusion capacity and hyperventilation of the patient, the arterial PCO2 decreases from 40 to 32 mm Hg. The residual volume also decreases approximately 20% from 1,500 ml to approximately 1,200 ml. And finally, chest wall compliance is reduced, which causes a 10 to 25% decrease in functional residual capacity. So now let's discuss some of the more common pulmonary diseases during pregnancy. First is asthma. Asthma is a chronic inflammatory airway syndrome with a major hereditary component. There is increased airway responsiveness and persistent subacute inflammation. Asthma is a heterogeneous disease, and there's always a requirement of an environmental allergic stimulant, such as an influenza or cigarette smoke, especially in susceptible individuals, to trigger asthma attacks. The hallmarks of asthma are the following: reversible airway obstruction from bronchial smooth muscle contraction, vascular congestion, tenacious mucus, and mucosal edema. There is mucosal infiltration with eosinophils, mast cells, and T lymphocytes that causes airway inflammation and increased responsiveness to numerous stimuli. Inflammatory mediators include histamine, leukotrienes, prostaglandins, cytokines, and many others. And because F-series prostaglandins and ergonovin exacerbate asthma, this commonly used obstetrical drug should be avoided if possible. The F-series prostaglandins are usually in the form of carboprost, and the ergonovin is in the form of methergine in our market. So this is a classification of asthma severity. So basically, we have the intermittent asthma and the persistent asthma. So under persistent asthma, this is subdivided into mild, moderate, and severe. So you can see here that we are able to classify the asthma severity in terms of the frequency of the symptoms, the frequency of nocturnal awakenings, the use of short-acting beta agonists, and of course the lung function test, the FEV1 and the FEV1 FVC ratio. And these are the clinical stages of asthma. So initially, the patient may present with just a mild respiratory alkalosis where the FEV1 is in the range of 65 to 80%, the PO2 is normal, however, the PCO2 is decreased. Of course, hypoxia is initially mitigated by hyperventilation of the patient, which maintains the arterial PO2 within the normal range, but of course, the hyperventilation also lowers PCO2, and therefore this creates respiratory alkalosis. Now, with continuing airway obstruction, of course, there is some more severe respiratory alkalosis, which leads to an FEV1 that's so much lower at 50 to 65%, and the PO2 is already slightly decreased. The PCO2 is also decreased. With ventilatory failure, of course, the patient goes into the danger zone. Danger zone meaning that the FEV1 is really very, very low at 35 to 50%. The PO2 is decreased and the PCO2 is normal. As airway narrowing worsens, the ventilation perfusion defects increase and arterial hypoxemia ensues. With severe obstruction, ventilation becomes impaired as fatigue causes early CO2 retention, and because of hyperventilation, this may only be seen initially as an arterial PCO2 returning to the normal range. Now, with continuing obstruction, respiratory failure follows from fatigue, and this could lead to death. Pregnancy has an unpredictable effect on the underlying asthma. In so many studies, it has been reported that approximately 30% or a third of these patients improve, one third or 30% remains unchanged, and another 30% or another one third uh, has an asthma condition that worsens during pregnancy. And studies have shown that exacerbations are very are more common with the severe form of asthma. Some women have asthma exacerbations that occur during labor and delivery. Now, as for the pregnancy outcome, unless the asthma is severe, then pregnancy outcomes are generally excellent, especially if the asthma is controlled. Increased morbidity appears to be significantly linked to severe disease, poor control, or both. The incidence of spontaneous abortion in women with asthma may be slightly increased, and the fetal effects is actually nil, especially with reasonable asthma control. Now, how do we clinically evaluate asthma? The useful clinical signs include labored breathing, tachycardia, pulsus paradoxus, prolonged expiration, and the use of accessory muscles. The signs of a potentially fatal attack in asthma include central cyanosis and altered consciousness. Arterial blood gla- Arterial blood gas analysis provides objective assessment of maternal oxygenation, ventilation, and acid base status, especially if the patient is in an acute asthma attack, and the results must be interpreted in relation to normal values for pregnancy. Pulmonary function testing should always be routine in the management of chronic and acute asthma. Sequential measurement of the FEV1 or the PEFR are the best measures of severity. The PEFR correlates well with the FEV1 and it can be measured reliably with inexpensive portable meters. An FEV1 that's less than 1 liter or less than 20% of the predicted value correlates with severe disease defined by hypoxia, poor response to therapy, and a high relapse rate. It is advisable for each woman to determine her own baseline when asymptomatic to compare these values with the values when they are symptomatic. And here are the principles of management for chronic asthma. First is, of course, patient education. General asthma management is always stressed in patient education and its effect on pregnancy. Next is environmental precipitating factors. We have to avoid or control the precipitating factors such as viral infections, including the common cold, which are frequent triggering events. Also, we have to do objective assessment of pulmonary function and fetal well-being. We have to monitor the PEFR and the FEV1. And finally, of course, we have to institute pharmacologic therapy. In general, women with moderate to severe asthma should measure and record either their FEV1 or PEFR twice daily. The FEV1 ideally is greater than 80% of predicted, and for PEFR, predicted values range from 380 to 550 liters per minute. The therapeutic adjustments can be made using FEV1 and the PEFR. Now, chronic asthma treatment depends on disease severity. So as you can see here, we have a stepwise approach to asthma treatment. So for mild intermittent asthma, we only give short-acting beta agonist for asthma attacks. For the mild persistent classification, we have to give short-acting beta agonist plus a low dose ICS. ICS here means inhaled corticosteroids. For moderate persistent classification of asthma, we have to give short-acting beta agonist plus a low dose inhaled corticosteroids plus a long-acting beta agonist or a LABA. For severe persistent asthma, we have to give short-acting beta agonist plus high-dose inhaled corticosteroids and a long-acting beta agonist. And for very severe persistent classification of asthma, you have to give short-acting beta agonist plus a high-dose inhaled corticosteroids plus a long-acting beta agonist plus an oral corticosteroids. Beta agonists help to relieve bronchospasm and corticosteroids treat the inflammation because, as we all know, corticosteroids are anti-inflammatory. Now, for mild asthma, we just need to give them inhaled beta agonist as needed. But for patients with persistent asthma, then we have to add inhaled corticosteroids and we have to give this every 3 to 4 hours. And the goal here is to reduce the use of beta agonist for symptomatic relief. Theophylline is a methylxanthine, and this can also be used as a bronchodilator and possibly an anti-inflammatory agent. However, this is used less frequently since inhaled corticosteroids became more widely available. There is minimal benefit with the use of these compounds and they have a very high rate of side effects. However, some theophylline derivatives are considered useful for oral maintenance therapy if the initial response to inhaled corticosteroids and beta agonist is not optimal. Anti-leukotrienes inhibit leukotriene synthesis, and this includes Zileuton, Zafirlukas, and Montelukast. Well, essentially, anti-leukotrienes are only used for prevention of asthma, so they are not used for acute asthma attacks. For maintenance, they are used in conjunction with inhaled corticosteroids to allow minimal dosing. Chromones, on the other hand, include cromolyn and nidocromil, and they inhibit mast cell degranulation. They are ineffective though for acute asthma, just like the anti-leukotrienes, and they are used primarily to treat childhood asthma. Treatment of acute asthma during pregnancy is similar to that for the non-pregnant asthmatic. Importantly, the threshold for hospitalization is significantly lower, of course, and IV hydration may help clear pulmonary secretions, and supplemental oxygen is given by mask. The therapeutic aim here is to maintain the PO2 greater than 60 mm Hg and preferably normal, along with 90 to 95% oxygen saturation. Baseline pulmonary function testing includes FEV1 or PAFR as already mentioned in the previous slides, and continuous pulse oximetry and electronic fetal monitoring depending on gestational age may provide useful information. Antibiotics are not given unless there is an infection or a concomitant pneumonitis or pneumonia. The first-line therapy for acute asthma includes short-acting beta-adrenergic agonists such as terbutaline, albuterol, isoetheret, epinephrine, isoprotrenol, or metoprotrenol, which is given subcutaneously, taken orally, or inhaled. In severely ill women, these drugs can be given IV. These drugs bind to specific cell surface receptors and activate adenylyl cyclase to increase intracellular cyclic AMP and modulate bronchial smooth muscle relaxation. Long-acting preparations are useful for outpatient therapy. If not previously given for maintenance, inhaled corticosteroids are commenced, and a nebulized anticholinergic drug may be added if the response at this point is not satisfactory. Also, for severe exacerbations, IV magnesium sulfate or theophylline may prove effective, and corticosteroids are given early to all patients with severe acute asthma. And unless the response to bronchodilator and inhaled corticosteroid therapy is prompt, oral or parenteral corticosteroids should be given. One regimen is oral prednisolone or IV methylprednisolone in doses of 30 to 45 milligrams daily for 5 to 10 days without tapering. And because their onset of action is several hours, corticosteroids are given initially along with beta agonists for acute asthma. Status asthmaticus is when a severe asthma is not responding after 30 to 60 minutes of intensive therapy. Consideration, of course, should be given to early intubation when maternal respiratory status worsens despite aggressive treatment of the asthma attack. And fatigue, carbon dioxide retention, and hypoxemia are indications for institution of mechanical ventilation. For the laboring asthmatic, maintenance medications for asthma are continued through delivery, and stress dose corticosteroids are administered to any woman given systemic corticosteroid therapy within the preceding 4 weeks. The usual dose is 100 milligrams of hydrocortisone given IV every 8 hours during labor and for 24 hours after delivery. Epidural analgesia is ideal during labor and delivery of a patient who is asthmatic. And for surgical delivery, conduction analgesia is preferred because tracheal intubation, which we do in a general anesthesia, can trigger severe bronchospasm. And as mentioned a while back, prostaglandin F series, especially prostaglandin F2 alpha, and this is in the form of carboprost, or ergotamine derivatives in the form of metrogyne or methylergonovin in the market, are contraindicated because they may cause significant bronchospasm in the asthmatic patient. Any pregnant woman suspected of having pneumonia should undergo chest radiography with abdominal shield to minimize the radiation exposure to the fetus. Typical symptoms of bacterial pneumonia include cough, dyspnea, sputum production, and pleuritic chest pain. Mild upper respiratory symptoms and malaise usually precede the symptoms, and mild leukocytosis is usually present. And these are the risk factors that should prompt hospitalization in a pregnant patient suspected of having a pneumonia. Actually, this is the criteria for diagnosing severe community acquired pneumonia. So that's a respiratory rate of greater than 30, PaO2 to FiO2 ratio of less than 250, multilobular infiltrates on chest x-ray, when there's already confusion or disorientation, uremia, or leukopenia that's or a WBC count less than 4,000, thrombocytopenia or a platelet count of less than 100,000, hypothermia or a core temperature that's less than 36, and hypotension requiring aggressive fluid resuscitation. With severe disease, admission to an ICU or intermediate care unit is advisable for a pregnant patient with pneumonia. Severe pneumonia is a common cause of acute respiratory distress syndrome during pregnancy. Antimicrobial treatment is usually empirical, and because most adult pneumonias are caused by pneumococci, mycoplasma, or chlamydophila, monotherapy initially is with a macrolide in the form of azithromycin, clarithromycin, or erythromycin. And here is a table that summarizes the empirical antibiotic treatment for pregnant patients with community-acquired pneumonia. For women with severe pneumonia, it is recommended to start them on a respiratory fluoroquinolone in the form of levofloxacin, moxifloxacin, or gemifloxacin. We can also use a macrolide with a beta-lactam. That's a high-dose amoxicillin or amoxicillin clavulanate, which are the preferred beta-lactams. Beta-lactam alternatives include ceftriaxone, cefpodoxime, or cefuroxime, which is preferred for high-level resistance of pneumococcal isolates to macrolides. And for community-acquired methicillin-resistant S. aureus, we use vancomycin or linezolid. Clinical improvement is usually evident in 48 to 72 hours with Clinical improvement is usually evident in 48 to 72 hours with resolution of fever in 2 to 4 days. Chest x-ray abnormalities may take up to 6 weeks to completely resolve, and pneumonia treatment is recommended for a minimum of 5 to 7 days. How about pregnancy outcome with patient? How about pregnancy outcomes in patients with pneumonia? Prematurely ruptured membranes and preterm delivery are the frequent complications in patients with in pregnant patients with pneumonia. And there's actually a twofold increase in low birth weight infants. Probably this is secondary to the hypoxemia that's related to pneumonia. Increased incidence of preterm and growth restricted infants, as well as preeclampsia and cesarean delivery, are also frequent complications of uh, pregnant patients with pneumonia. How about pneumococcal vaccine? There are two pneumococcal vaccines available in the market. There's the 23 serotype older preparation and a newer 13 serotype vaccine. The 23 serotype vaccine is 60 to 70% protective, and its use lowers emergence of drug-resistant pneumococci. The 13 serotype vaccine is not recommended for otherwise healthy pregnant women, but it is recommended for women who are immunocompromised, including those with HIV infection, significant smoking history, diabetes, cardiac, pulmonary, or renal disease, asplenia, such as sickle cell disease. The third is influenza pneumonia. Influenza A and B are RNA viruses that cause respiratory infection, including pneumonitis or pneumonia. And this virus is spread by aerosolized droplets and quickly infects ciliated columnar epithelium, alveolar cells, mucous gland cells, and macrophages. Disease onset is 1 to 4 days following exposure to someone with influenza, and common symptoms include fever, cough, myalgia, chills, and in most healthy adults, infection is self-limited. How about treatment of influenza? Usually, as we all know, the treatment of influenza is supportive, and early antiviral treatment is effective also for these patients. Hospitalization is considered for severely ill women, and the CDC recommends neuraminidase inhibitors given within 2 days of symptom onset for chemoprophylaxis and treatment of influenza A and B. And neuraminidase inhibitors are drugs that interfere with the release of progeny virus from infected host cells and thus prevent infection of new host cells. Um, the neuraminidase inhibitors come in the form of oseltamivir or zanimivir. Oseltamivir is given orally at 75 milligrams twice daily, and zanamivir is given by inhalation 10 milligrams twice daily. Recommended treatment duration is 5 days. This drug shorten the course of illness by 1 to 2 days, and they probably reduce the risk for pneumonitis. And the drugs are not teratogenic in animal studies, so they can be given for pregnant women. Vaccination for influenza A is recommended by the ACOG and the CDC. And lastly, we talk about pulmonary tuberculosis. Tuberculosis is infection via inhalation of the Mycobacterium tuberculosis, which incites a granulomatous pulmonary reaction. Manifestations include cough with minimal sputum production, low-grade fever, hemoptysis, and weight loss. Various infiltrative patterns are seen on chest x-ray, and there may be associated cavitation or mediastinal lymphadenopathy. Acid-fast bacilli are seen on stained smears of the sputum from a patient with tuberculosis. So how do we diagnose tuberculosis? Two types of tests are used to detect latent or active tuberculosis. One is the time-honored TST or the tuberculin skin test, and the other is the interferon gamma release assay or the IGRAs, which are becoming preferred. And IGRAs are blood tests that measure interferon gamma release in response to antigens present in Mycoplasma tuberculosis, but not Bacille Calmette Guerin vaccine. And the CDC recommends either skin testing or IGRA testing of gravidas or pregnant women who are in any of the high risk groups. For those who have received BCG vaccination, IgRA testing is used. For skin testing or the tuberculin skin test, the preferred antigen is the PPD or the purified protein derivative of intermediate strength of 5 tuberculin units. If the intracutaneously applied test result is negative, then no further evaluation is needed. A positive skin test result measures greater than 5 millimeters in diameter and requires evaluation for active disease, including a chest x-ray. The recommended initial treatment for active tuberculosis in pregnant patients is a 4-drug regimen, and we all know this. This is the isoniazid, rifampin, ethambutol, and pyrazinamide, plus, of course, pyridoxine. For the bactericidal phase, this is the first 2 months of the treatment. All 4 drugs are given. For the continuation phase, that's the remaining 4 months of a 6-month regimen, we just give the isoniazid and the rifampin. Breastfeeding is not prohibited during antituberculous therapy. And of the second line regimens, we cannot give the aminoglycosides such as streptomycin, kanamycin, amikacin, and capreomycin because all these drugs are ototoxic to the fetus. For the latent tuberculosis, we only give isoniazid for 9 months. No need to give the 4-drug regimen for a latent infection only. Latent infection means that the patient tested positive for the skin test but has no active signs of disease. For neonatal tuberculosis, tubercular basilemia can infect the placenta, but it is uncommon that the fetus becomes infected or what we call congenital tuberculosis. Neonatal tuberculosis also applies to newborns who are infected by aspiration of the infected secretions at delivery. Neonatal infection is unlikely if the mother was with an active disease has been treated before delivery or if her sputum culture is already negative. However, if untreated, the risk of disease in the infant born to a woman with active infection is 50% in the first year. Neonatal tuberculosis simulates other congenital infections and manifests with hepatosplenomegaly, respiratory distress, fever, and lymphadenopathy. So, in summary, we have discussed some physiologic pulmonary changes induced by pregnancy, such as changes in the vital capacity, expiratory reserve volume, tidal volume, minute ventilation, and residual volume. We also discussed the 4 most common pulmonary diseases in pregnancy, such as asthma, bacterial pneumonia, influenza pneumonia, and tuberculosis. That's it for this lecture. Thank you for watching this lecture and please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigaine. Thank you.